of death and third leading cause of death and disability in the world. To have our next presentation on the topic of stroke, the updates in the management, we have Professor Qasim Bashir, one of the best and top clinical interventional neurologists, who is MBBS, MD USA, Fellow Royal College of Edinburgh, Fellow Society Vascular Interventional Neurology, Neurocritical Care Board Certified, Vascular Neurology Board Certified, USA Certified Neuro Endovascular Surgery. He is Head of Department of Neurosurgery at Services Institute of Medical Sciences. He is basically Head of Department of Neurology. Thank you so much, sir, for being here. The stage is over to Professor Qasim Bashir.
इस पे लगाया, ये मेरे पे लगा, आपने मेरे वाले पे लगाना था। इधर तो आ रहा है।
विजय दे दो,
विजय लगा। Assalamu alaikum everyone. Thank you, Ms. Hina, for the kind introduction. I would like to take the opportunity to express my special thanks to all the organizers of this conference for what I believe is the most important topic, because acute stroke, 1 in 3 of you in this room unfortunately will have in some point of life some neuro problem. And stroke is a very common one in neurology. So the other thing is that the way I designed this talk is more about giving the guidelines in line with the current realities and where the joint work needs to be done, because neurology and internal medicine are two very important aspects when it comes to the emergency room interactions. And I don't think that without internal medicine, this stroke care is going to improve in Pakistan, and that's what I've tried to highlight over here. So I have no conflict of interest in any things that I'm going to talk about. Starting forward, the ground realities. I'm just going to share a recent case. A 46-year-old man with hypertension and diabetes comes to a public hospital, which is like 10 or 15 minutes away from Services Hospital Lahore. So this is the initial scan, and you can see that the family reported that the stroke onset took place 4 hours before they brought the patient to the emergency room. And the CT scan is already showing you these hyperdensity on the right side of the brain, right over here. So this is all phased out. So just look at 46. Stroke is evolving very rapidly. So the family comes to know about that at Services Hospital we're giving TPA. The patient is shifted early in the morning, and by the time the neurology is called and we do late afternoon scan, this is the evolution. This is a matter of like 12 to maybe 12 hours. So, and now he already has a midline shift. When he came to us, he was already brain dead. So this is an evolution of a malignant stroke. So what are the lessons that one learns from this case? So the lesson is that the public education is direly needed. Physician education is direly needed. There is a lack of standardized national emergency response system. We all need to promote 1122 nationally. This is a very important topic that I go around everywhere, because there has to be a one national ER number, emergency number. Unfortunately, in every city there are so many charity ambulance services and everything, and that actually fragments the care that the patients need, not only for neurology but for everything else. We don't have dedicated stroke centers, and like I said, the physician education. In this case, the patient didn't need to be transferred. All he needed was an emergent decompression by neurosurgery to save the life, because this was a right hemisphere and he was 46-year-old. He could have easily survived this stroke. So, but this, and then lastly, because of everything is linked with the dollar, so the currently all issues with the disposables, the cost of the disposables is a limiting factor as well. When we look at the developed countries, this is what they're doing. They're trying more on the prevention and early aggressive treatments, because they're trying, the whole emphasis is now switched to prevention and making more stroke survivors, so that it's less of a burden on the community. So this is the 21st century care in the developed countries. And we are still in the 19th century, because this is the usual mode of transport for the patients who are coming to the hospitals with acute strokes. It's not recognized. This patient probably would have aspirated, desaturated by the time he's being brought to the hospital. So this is where we are at this point, which is very unfortunate. Now, moving forward, the one thing that is very important is, unlike acute coronary event or angina, the heart is all muscle, brain is all neuron. The muscle will regenerate if the flow is restored, but the neuron, once it's dead or ischemic, will not regenerate. So we are actually fighting more against time as compared to the myocardium, and every minute that the stroke is evolving, approximately 2 million neurons are dying, and an average adult brain, usually there are 25 to 28 billion neurons. So all the neurons that are dead. So anything that we do when the patient comes to the hospital, we are actually trying to save this evolution and try to limit the extent of the damage. By the time I'm done, I'm hoping that all of you who even at this point maybe in the audience thought that the stroke is not treatable will know that the stroke is treatable. So when we're dealing with the brain, the thrombus pathophysiology is relatively different than what you are dealing with the heart. And there are a host of problems because the vasculature is way different than the myocardium, and we have a lot of small vessels, large, medium, and small size vessels. So and then the extent of the clot burden can come from the heart, it can come from the extracranial circulation, the carotids and the vertebral arteries, and you can also have people who are resistant to thrombolytics or to antithrombotics. So before we move into the stroke, I just want to refresh the memory for the transient ischemic attack, because this is an important definition that was revised in 2009, and it was revised at par with the current acute coronary, namely the myocardial infarction or angina. So the difference between angina and the myocardial infarction is primarily that in infarction there is a tissue damage, and in angina there is no tissue damage, and that you differentiate with the ECG and with the cardiac enzymes. But same thing with the TIA, the definition was changed in the same line. So the TIA is now defined as any transient episode of neurological dysfunction caused by focal brain, spinal cord, or even retinal ischemia, but please note, without acute infarction. Now, with this definition, the responsibility is actually on the physician treating the patient to prove whether if the patient has improved, the patient did have stroke or did not have stroke by ordering the imaging, namely the CT scan, the MRI being more sensitive. The important part is that if you don't recognize this thing, if you look at the patients who have TIAs, within the less than 24 hours, 4% of them will blossom into a full-blown stroke, as compared to someone coming with angina, only 2%. So the risk of a TIA going into a stroke is double than angina into an infarction. So that's the important piece. TIAs from intracranial circulation. You can also have TIAs from extracranial circulation. I talked about this ABCD2 score. It's a very important validated scoring system. A for age, B for blood pressure, clinical features, and, duration of symptoms, and diabetes. So from internal medicine, the role of hypertension control and diabetes has to be very, aggressively there. So when we are dealing with the stroke patients, we send them back to their community internal medicine physicians or the family practice one with strong emphasis that while we have dealt with the issues, the further prevention can only be if you're controlling the risk factors. Otherwise, the patients are going to keep on coming back. And the score translates into the probability that in the first 2 days, how much risk is there for these patients to end up having a full-blown stroke. So very easy, a validated scoring system available in your smartphones, something that everyone should know. Now moving forward, the stroke types. Today I'm just going to be talking about the ischemic strokes. They constitute about 85% versus hemorrhagic, which is 15%. You can have intracerebral hemorrhage, subdural, subarachnoid, there are different types. Other important thing that from this classification is that please, when you see a stroke patient or you diagnose someone as a stroke patient, please do not write CVA. CVA stands for confused vascular anatomy. This is an old acronym. It basically means you don't know what the underlying pathophysiology is. If you don't know the underlying pathophysiology, you're not going to treat the underlying problem that the patient is coming in with the stroke. It could be heart, it could be blood pressure, it could be diabetes, combination, smoking. You need to put the patient type somewhere here, so that the risk factors are controlled. If the patient goes to physician XYZ, they know why the medications are there and they cannot or should not be stopping, especially if they know that it's atrial fibrillation, and you should not be touching on the anticoagulation. So ischemic stroke, whenever there's going to be a blood flow interruption, it's called ischemic flow as compared to vessel rupturing. On a CT scan, a subacute stroke will look like a hypodensity, and a hemorrhage will look like a hyperdensity with ventricular extension or whatever, and a lot of mass effect. Hemorrhagic strokes bring forth mass effects more quickly as compared to the ischemic strokes, so that's another important clinical differentiation. Now moving forward in the therapies, in the ER, in the first 4.5 hours, the drug of choice will be the IV TPA. That's the only drug available and approved by FDA and the counterpart European countries as of today. Anyone in 0 to 24 hours can be considered for thrombectomies and even with IV TPAs, but the first treatment line, defense line, will be the IV TPA. The patients who do not improve with TPA or are failing TPA or do not qualify in this window can be put in this bracket and dealt with. But as far as the guidelines are concerned, all those patients who are eligible must receive IV TPA even if they are endovascular candidate. And studies have shown that if the patients are treated actually within 3 hours and they respond to the treatment, you can add 4.5 years of healthy life free of disability, which is a very, very large number. So, a very important take-home message. So, when we're dealing with the stroke, these are the four paradigms where the patient is going to be moving. If they are well outside any of these three domains, they are going to be dealt with conservatively, basically risk factor control, ICU care. But otherwise, if they are in the acute window, TPA plus minus any of these therapies based on the time frame. So this is just a working chart, like how at our hospital we deal with the patients. Anyone comes in with acute stroke will have a CT brain. The neurology is called upon. They have to decide whether this is a large vessel, small vessel, IV TPA, mechanical, whatever, but there is a flow chart that we have to follow. This drug was approved by FDA in 1996, but in Pakistan it was approved only in 2020. So just imagine how far away we are from the developed world. So in the emergency room, this is a special slide that I made for this conference, because like I said, that I am working in the public sector and the private sector, and the problems are pretty much the same. And the main problem is that in the ER, the ER is divided into medicine and surgery. That is also not the way it should be. It should be the allied specialties who deal with emergencies should be part of the emergency room teams. Otherwise, the patients are going to get neglected. Not everyone is up to date on the guidelines, and it's all about teamwork. So the team has to know what their role is. The nurses have a very important role, but everyone must be aware of their role, and without any question, if the patient comes, they should just start carrying out their work as far as the work designations are concerned. And why is it important? Because I said that it's all race against time. For every 20 minutes we are delaying, the number needed to treat for TPA is going to increase. And that basically means that if the patient comes in 1.5 hours, for every 4 patients we're going to treat, 1 is going to benefit. As the time evolves, the more patients need to be treated to get 1 positive effect. So that's an important piece of it. So if a patient comes in 15 minutes, it doesn't mean that you say that you have 4.5 hours, we can go slow in the ER. It means that you need to actually expedite, because that is a perfect patient. So like I said, it's all race against time. So once you've identified the stroke patient, the first and the most important question is not about who you are, what's your age, is the last known well time. What we write as abbreviation as LKW, because that's where the clock starts. So once the stroke has been recognized, if it's an outside hospital stroke, must consider using the ambulance service rather than trying to bring them in your own cars, because studies have shown that people coming in with sirens on an ambulance, they actually reach hospital quicker as compared to trying to use their own private transport. So this is an important grid, because this is the same grid that the cardiology follows, the golden hour principle. So the golden hour principle is that 0 minutes, 10 minutes, 15, everyone has a role to play, and then within 60 minutes, it has to be decided whether the TPA is going to be given or not, and then the TPA is administered based on the exclusion and inclusion criteria. And the only thing right now, I'm just not going to go into the details. One important piece of information is that anyone who is below 80 years of age, the TPA window is up to 3 hours. The 1.5 hours extension does not apply to people who are 80 and above. So the thrombectomy and those type of things can be considered. So that's an important differentiation point. And also the other important point is, if you have any history of stroke and diabetes, together, you are not eligible in this window for 1.5 hours extension. So that's a very important thing to remember. So the importance of the diabetes and the stroke together. So I'm not going to go through all of these things, because this is mostly the role of the neurologist who have to go through all the exclusion and the inclusion criteria. But just to tell you, highlight you the fact. So this is how the TPA looks like. It comes in a box with 2 vials of 50 milligrams and 2 vials of 50 cc of sterile fluid. There is a special way of how to mix it and then administer it. The important piece is, this is where some of the neurology guidelines as far as blood pressure regulation and diabetes regulation slightly differ from internal medicine and the endocrine. We have to keep it below 185 and 105 if you are going to give someone a TPA, because again, the risk for a hemorrhagic conversion is more if the blood pressure is not regulated. And we tend to use labetalol, hydralazine, enalapril, the IV medications for controlling the blood pressure. So it has to be dealt with very aggressively in the first 24 hours. Like the blood pressure, the diabetes is very important, because again, you can subject the patient to hemorrhagic conversion if the blood sugars are not regulated. So I've seen the internal medicine, some people being liberal with 200, 250 in the acute phase, but not for acute strokes. And you want to avoid hypoglycemia, but the goal is to keep them in the normal glycemia, and always use subcutaneous insulin. Do not put them on any oral hypoglycemics or long-acting insulin. As long as in the hospital, regular subcutaneous insulin is sufficient with a good sliding scale. So a brief word on how we started. It was a project that was funded by philanthropy, Punjab Health Government, and we were able to get TPA at the Service of the Hospital for first 135 patients. The project was started in 2020, but we actually got the drug in 2021. So far, we have dealt with 16 patients from the discharge of 3 months, 41% improvement, 3 mortalities, all 3 mortalities because the TPA did not work, and those were malignant strokes, but no complication from TPA. So now lastly, the thrombectomy. From 2012 till 16 or 18, there were 5 major international trials, randomized trials, that actually collectively showed that the endovascular therapies do work, but with this thing, the first 8 hours are most important for patient selection. The window can be extended for 24 hours, but for anything beyond 6 hours, we require CT perfusion. Those are part of the guidelines. So even if the patient is eligible for IV TPA and endovascular, the patient will get IV TPA, will move to the cath lab, and then the thrombectomy can be done. And usually the endovascular therapy is reserved for patients who have moderate to severe strokes, which can be judged based on the clinical examination. And the guidelines right now is a class 1 recommendation for large vessel occlusion, namely the MCA, the interior circulation. When it comes to the smaller branches, it's a class 2B recommendation that you can consider endovascular therapies. And anyone beyond 6 hours to 24 hours must have either a CT perfusion or MRI diffusion and a T2 flare sequence in order to figure out whether the patient will qualify for this time period or not. Otherwise, you cannot do this thing. So when we are doing the reperfusion therapies, there must be a goal apart from the fact the most important one is that whether this recanalization will translate clinically into a good outcome. So angiographically, this is what we are looking for. Same thing with the coronary angiography. They have TICI scores. We have also TICI scores. And the therapies are mix and match of intra-arterial, TPA, sometimes streptokinase, stent thrombectomies, aspiration devices, microwire manipulation. So there are different techniques, different devices that we tend to use. Another take-home point is that unlike cardiology, as I said, we are dealing with the neurons. There is a large chunk of patients who are actually going to show a good angiographic outcome, but that outcome is not going to translate clinically. So this is a recent case where the patient actually came in a very good time. Within 5 hours, he was recanalized, but did not translate clinically. So ended up having a complete stroke, even though everything was working very smoothly for him. So this is an example of a futile recanalization, that meaning that angiographically it was recanalized, but clinically it did not translate. So the last couple of slides are just about some cases. Strokes can, just like acute If anyone knows that who is interested in car racing, the world record actually for the Red Bull team to change the 4 tires is 1.9 seconds. And there are 20 to 24 people working on one pit, and there is one lollipop man standing right here in the front, just like when we're doing the ACLS and those type of things. So if imagine a patient in the same scenario with all of these specialties at the bedside, but the problem that we face is that we are not synchronized, and everyone is working in their own direction, and that's the biggest problem right now in the hospitals. So it's a teamwork. Without the teamwork, it's not going to work. Thank you so much.